My talk will be on the approach to a child with respiratory failure. I'm Dr. Ullah, working as consultant peds intensivist at Shifa International Hospitals Ltd. I've got nothing to disclose, including all the faculty, speakers, and the senior planning committee with no financial disclosures. Objectives of the talk will be the definition of respiratory failure, the types, a few important causes, signs, symptoms, and management. So let's talk about the definition first. So respiratory failure, as you know, the functions of the respiratory system is one is oxygenation, in which there is oxygen uptake into the blood, and the other is ventilation, where there is CO2 removal. So if there any of the above function is either lost or altered, you can simply call it as respiratory failure. Conventionally, it is divided into two types, the type 1 and type 2. And the type 1, it is the hypoxic type, where the oxygen saturation of the oxygen concentration is low in the blood. And type 2 is the hypercapnic type. But some of the references, they also give another two types. The type 3 that is usually happens in the post-operative patients, that is due to the pain and abnormal abdominal wall or the abdominal musculature mechanics. And type 4 is due to shock. The shock one, it happens because already as discussed by Dr. Abid, that there is decreased oxygen delivery into the tissues. So actually the respiratory system is intact in the shock, but if the delivery is decreased, then you can also classify that as acute respiratory failure, because ultimately there is decreased oxygenation and decreased tissue perfusion. Before we go into the types of the shock, there are a few important concepts which need to be understood. Because there will be a brief introduction about most of them. The first one is the alveolar arterial gradient. They also call it ADO2. It is actually the gradient or the difference between the oxygen content of the alveolus and the oxygen content of the arterial blood. Normal value is about 4 to 50 millimeters of mercury. There is a formula which is described, in the context here is basically the FiO2 times the atmospheric pressure minus the hydrostatic pressure, water pressure, and minus PiCO2 divided by 0.8 into PO2. It's a difficult formula, but at the end, if you do the calculation, it comes as FiO2 times 713 because 7 is our O2 pressure, and minus that PaCO2 comes from the arterial blood gas, the one which is divided by 0.8, and minus PaO2, which also comes from the arterial blood gas. So what is the clinical implication of the A2 gradient? Because it is increased in patients who have diseased lungs, while it stays normal in patients who have hypoventilation, in those patients, especially where the lungs are normal. So those patients who have type 1 respiratory failure, which most of the causes where there is ventilation perfusion mismatch, the A2 gradient will increase. And it's very simple to calculate. If you have an arterial blood gas, you can simply calculate the A2 gradient. The other important concept is basically, the shunt versus depth space, or you can call it the ventilation perfusion mismatch. There are three alveoli which are drawn here. The first one, if you see in the first one, there is blockage in the alveolus. That means the ventilation is affected. Okay, it happens normally in pneumonia or ARDS, where the perfusion to the alveolus is normal, but the oxygenation is affected. So we call the VQ mismatch as nearly zero. They've labeled here as 1/10 because maybe there is some ventilation, but you can call it as nearly zero. But nature has kept that if there is a decreased ventilation to any alveoli, the nearby vasculature, it gets constricted and automatically the perfusion will also decrease. That's a natural response, but doesn't always happen. So there will be always some degree of ventilation perfusion mismatch in those alveoli where there is poor ventilation. The middle one is normal, where the ventilation perfusion, it's in the normal ratio 10/10. The deoxygenated blood will come, it will oxygenate as fully, and then it will leave. So it is nearly zero, this ratio. And in the last one, where the ventilation is normal, it is 10, but the perfusion is affected. It typically happens in patient with like pulmonary embolism or where there is decreased perfusion to any part of the lung. So the first one, the first alveoli, you can call it as shunt, and the last alveoli, you can call it as a dead space, because dead space, there is ventilation, but no perfusion. So again, that ventilation that goes wasted. Okay, and this VQ is nearly like it is close to infinity. The other concept is, we know it from our knowledge of physiology, is the oxyhemoglobin dissociation curve. That's the sigma-shaped curve normally, and in conditions where if there is acidosis or there is increased 2,3-diphosphoglycerate, which happens in patient with increased metabolism, and in hyperthermia, the shift is towards the right. A right shift would mean there is decreased affinity of hemoglobin for the oxygen. That means more oxygen will be delivered to the tissue, because it will, at the tissue level, if the affinity is low for the hemoglobin, then it will dissociate from the hemoglobin and get delivered to the tissues. While in the left shift, there is increased affinity for the oxygen. That means less tissue oxygenation will happen, and it typically happens in patients who have alkalosis, decreased level of 2,3-phosphoglycerate, and in hypothermia patient, and also in HbF, because it has got increased affinity for the hemoglobin. The other concept is oxygen extraction ratio. As we know that normally our oxygen saturation in the arterial blood gas is nearly 95%, and the venous blood gas is around 70 to 75%. So that would mean that 20 to 30% of the oxygen is extracted in normal condition, I'm talking about. But if there is a critically ill patient who is in shock, this extraction ratio can increase up to 70 to 80%. That would mean that if the arterial saturation is 95%, the venous saturation can come down even to like 20 or 30%. That means 80% of the oxygen that is in the arterial blood gas will be extracted by the tissue. That typically happens in the shock, as discussed by Dr. Abid, that mixed venous oxygen saturation is important. And the last one, we usually normally PA2/FiO2 ratio is we calculate in patient with ARDS. Normal is more than 300, but if it is less than 300, it indicates acute lung disease. So going to the type 1 respiratory failure, which is of course the commonest type, and it typically happens in acute lung disease to start with. It will happen first, the hypoxic type, and then it is usually followed by the hypercapnic type if it is a severe lung disease. So how do we define hypoxia? It is defined as the oxygen content or the partial pressure of oxygen in the arterial blood gas of less than 60 millimeter of mercury, or the oxygen saturation of less than 90%. If you see the table below, it gives you the corresponding PaO2 for the saturation level. So if the saturation is from 98 to 100%, the corresponding PaO2 will be typically more than 80 millimeter of mercury. And for 90, it is typically 60 millimeter of mercury. For 75%, it is 40. And for 50% saturation, it comes down to corresponding PaO2 of 26 millimeter of mercury. We can apply it for those conditions where the blood gas facility, because we know that in most of the peripheral hospital, we don't have blood gas facility. So even the saturation can tell you what is the corresponding PaO2 will be.
So in type 1 respiratory failure, there is hypoxia, the PaCO2, that is the CO2 content of the arterial blood gas. It is typically either normal or decreased. So why is it decreased? Because a slight increase in the respiratory rate can cause, like, a washing CO2. So that's why the PaCO2 initially it will be normal or even low. And most of the cases where there is ventilation perfusion mismatch, the ADO2, the formula which we discussed earlier, it will be elevated. That means the alveolar gradient and the oxygen gradient will be high. That typically happens in most of the lung disease where there is diffusion problem. Common causes, as we discussed earlier, ventilation perfusion mismatch. Diffusion problem is like, if there is if the alveolar surface is involved, either due to infections like pneumonia or ARDS, the ventilation perfusion mismatching, it can happen also in the pulmonary embolism, as we discussed earlier in the last alveolus, that there is there is no perfusion, but there is ventilation. So it acts as a dead space. And the cardiogenic or non-cardiogenic pulmonary edema, again, reason is the same, that alveoli are wet, and the mechanism is the same as like ventilation perfusion mismatch. If there is decreased oxygen content in even in the air, like it can happen in the high altitude areas. Even alveolar hypoventilation, though typically it can cause type 2 respiratory failure, but it can also give you type 1 respiratory failure. And the right to left shunt, which happen in congenital heart diseases, it can be either anatomical or a physiological right to left shunt. Going to the type 2 respiratory failure, the definition is that there will be hypercapnia. In type 1, there is no hypercapnia. Remember that we have either a normal or a decreased CO2, but in this one, the CO2 increases in the arterial blood gas to more than 50 millimeter of mercury. And usually there is associated hypoxemia as well. So respiratory type 2 respiratory failure does not mean that only the CO2 is affected, but in most of the cases, the PaO2 will also be low. And type 2, it can be divided into acute, chronic, or acute on chronic respiratory failure. So what happens in the acute one is that usually the pH is decreased, so there will be acidosis, there will be increased PaCO2, and the bicarbonate is usually normal because it does not give you enough time to compensate like what happens in the renal compensation. In the chronic one, the pH becomes normal because of in the renal compensation, where the bicarb will go up, but the PaCO2 will still be high. So if you look at the blood gas, normally you can call it a compensated respiratory acidosis. And on the acute and chronic, both the bicarb will increase because the ongoing renal compensation is also happening. CO2 will also go up because there is acute and chronic. So, and the pH will be low. So the difference between the acute and chronic is basically on the pH. Causes of type 2 respiratory failure, either reduced breathing effort. It can happen in drugs, if they've given sedatives, and even some brain stimulation, though they are usually not very common. In severe airway resistance, like in those with asthma and severe ARDS or suffocation, it can give increased airway resistance and give you type 2 respiratory failure. Neuromuscular problem like the GBS, and also in some deformed chest, which happens in the patient with the severe cerebral palsies or the musculoskeletal problem, because the size of the chest or the size of the lungs is really low. This is a slide from the pediatric advanced life support. The pulse, how do you differentiate a respiratory distress from a respiratory failure? So in respiratory distress, usually the airway is open and maintainable, but in the failure it is lost. There is usually bradypnea in contrast to tachypnea. And even in later, later part, even it can lead to apnea as well. There's decrease or absent air entry in the chest. There can be bradycardia, but usually in distress there is tachycardia, and it can give you cyanosis and lethargy and unresponsiveness. So why respiratory failure? We're discussing that. As we know that, if we talk about the inpatient cardiac arrest in pediatrics, in contrast to adults, most of the adult cardiac arrests are due to arrhythmias. And it is usually sudden. That's why, the cardiovascular part becomes very important in adults. But in contrast, in the pediatrics, 70% of our cardiac arrests are due to respiratory failure, actually. And the circulatory failure, like shock, it comprises about 15 to 20%. And the sudden one is like the arrhythmias or the sudden cardiac arrest is only 10 to 15% of the patient. So if you identify and if you treat the respiratory distress and respiratory failure in time, you can prevent actually 70% of cardiopulmonary arrest. Because, if the arrest happens, then usually the story is over. We come to the management. So if you have identified that if a patient is in respiratory failure, the first thing that, very basic, if you are working in a tertiary or secondary or even a primary care hospital, is that, you check for the ABC, airway, breathing and circulation. What we do in the airway is that, check if there is any secretions, you go for suctioning, you do the positioning. We'll discuss one by one in a little bit details. For breathing, you check the respiratory rate, effort, and air entry. For circulation, you look for the heart rate and capillary fill time and blood pressure. The first thing that needs to be done in any respiratory failure is you usually start with a high flow oxygen. We call it simply a 100% oxygen with whatever technique possible. If it's a non-rebreathing face mask or even a high flow by nasal cannula. So you try to keep the saturation more than 90%, but you remember that, the patients who have chronic lung disease and who are in chronic respiratory failure, you need to be a little conservative about the oxygen, because in those patients in whom CO2 remains very high for a long time, the trigger for respiration, it shifts from the CO2 to oxygen. So if the body is used to a low oxygen content, and if you suddenly increase, the oxygen content of the blood, it can give you sudden apnea. So caution in chronic lung disease and chronic respiratory failure, but in most of the cases, usually the treatment of respiratory failure start with the oxygen. So in the airway, simple things to improve the patency is suction from the nose and nasopharynx. And for positioning, head tilt and chin lift or a jaw thrust maneuver. So head tilt, chin lift for those patients in whom you don't suspect any trauma. And it is simply done by this technique, the one which is mentioned in the A. So one of the hand, you put it on the patient's forehead, and the other one is below the chin, and you just slightly extend the neck. So that will help to straighten the airway and at least relieve if there is a partial obstruction. In the jaw thrust one, it's actually not shown here, but you simply put both the hands on the side of the, the head, and you rather extend the lower part of the jaw. You don't move the head, because if there is a suspected, trauma to the spine, then you need to follow the jaw thrust maneuver. The other things to open, as you know, that you cannot keep this position for a very long time. I mean, not always. So the other adjuncts are either nasopharyngeal or the oropharyngeal airways. What do we do in the suctioning? That, there are this table gives you how much negative pressure you can use for newborns, usually 8 to 10 kPa. And if the age advances, it can go even up to 20 kilopascals of the negative pressure. Don't go more than that, because it can give you mucosal trauma and bleeding. What suction can do is that it can give you hypoxia, brief hypoxia, decrease heart rate because of vasovagal maneuver, bronchospasm, and even a laryngospasm. So you need to be careful about the suctioning. Usually what we do, that in the catheter, you insert the catheter first, and then you put the finger on the, the hole which controls the negative pressure. And then when you are coming back, at that time, you apply the negative pressure, not before that. Nasopharyngeal airway. So it is used in those patients who are either conscious or semi-conscious patient. And usually you do not use in patients who have suspected basal skull fracture, and you must select the appropriate size. So what is the appropriate size? It starts from the, from the tip of the nose down to the trachea or the angle of the jaw. So that's the appropriate size that you can use. You simply insert it from the nose. It's better to lubricate it, and then you can simply do the suction from it, and you can even apply, you can apply the oxygen, and the patient can breathe through it. The oropharyngeal airway, it is used in the unresponsive patients because the oropharyngeal airway, it will cause cough and gag. That's why if a patient is conscious, you better avoid it, and then you go for the nasopharyngeal airway. What it does actually, that it also relieve the upper airway obstruction if it is due to the tongue, which usually goes back to the posterior pharyngeal wall in patients who are unresponsive. And if the patient become responsive and start to fight, then you better change it to the oropharyngeal airway, the nasopharyngeal airway rather. Choosing the correct size of the opiate. In this one, the size, it starts from the angle of the mouth down to the either the tragus or the angle of the jaw. You insert it in the inverse position, insert it first, and then you straighten it. And if the size is either too small or too large, what will happen is that the small OPA will not adequately displace the tongue. And if it is too large, it may go back and it may obstruct the posterior pharyngeal wall. The next thing that if if you with your suction, your positioning of the airway and giving oxygen, if it does not relieve your, does not improve your saturation or does not improve your breathing, then you can simply go to the bag mask ventilation. But in those patients in whom the breathing effort is low, you can even from the start go to bag mask ventilation. So if there is inadequate breathing despite the patent airways, you can simply go and provide oxygenation ventilation by bag mask. There are different sizes. You need to know which one do you use for which patients, because there are different volumes of by the ambu bags. And we remember that the bag mask ventilation can be as good as even through ETT. Like if you are in trouble, if you're if you're facing a difficult ventilation or difficult intubation, you simply go for bag mask ventilation and call for help. So the EC clamp technique is used for the ambu bagging. It should cover your nose and mouth, and it should be above the chin. It shouldn't come below the chin because it will give you a lot of leak, and it shouldn't cover the eyes as well, because there is a risk of ear leak around the eyes also. So what is ENC? That your thumb and your index finger is producing a C, and your three fingers which are below the chin, it makes an E. So in usually pediatrics, a single person can provide both ENC technique in a single patient. But if it's an adult patient, or if there is a significant leak or a lot of resistance, then you can even the two persons that both hands of a single person will produce ENC, and the other person will be doing the bagging. How do we know if the patient is having an effective ventilation or not? You simply look for the good chest rise with each breath. Your oxygen saturation will improve. If you have available entitled CO2 monitoring, you can go, and entitled CO2 will come down gradually. There will be improvement in the heart rate, and if you auscultate the chest, there will be a good chest rise. If your ventilation is somehow not effective, you have done everything, your position, your suction, and it's not getting better, you go back, reposition him, and apply, oropharyngeal and nasopharyngeal airway. Verify that you have a proper size mask, as we discussed earlier. It shouldn't be very large or very small. Suction the airway again, check your oxygen source and the flow. Check the appropriate size, if you are using an appropriate size bag or no. And treat gastric inflation. Is better that if you're going for a ambu bagging, especially for a prolonged period of time, you better put in nasogastric tube first and decompress the stomach. If your saturation still does not improve, the patient is not getting better with big mask ventilation, you can, like, before you consider ventilation, you can consider even a non-invasive techniques. There are different interfaces used, and there is mouth and nose mask. There is a simple nasal masks only, and there can be a full face mask. So whatever interface suits you or suits the patient, you can use it. You can even use your ventilators with in those who have non-invasive modes, or otherwise you can use the machine which is used here, is shown below, that you can use it for the BiPAP purpose. If your patient is not getting better with the non-invasive, or you can see that the patient is in need of intubation, then we better, like, patient with respiratory failure, we go for the rapid sequence intubation. So the concept of rapid sequence intubation is that, you make an emergent intubation, it should be safe and effective, and you ultimately increase the success rate and decrease in the complications of intubation. So what is basically that we do in the rapid sequence is that, you give sedation and neuromuscular blocking agent. And so there are the 7 P's of RSI, the rapid sequence: the preparation, pre-oxygenation, pre-treatment, that's sedation, paralysis induction, protection and positioning, very important, placement of the ETT with proof. You made sure that your ETT is in place, and then you post-intubation management starts. These are the preparation for the RSI, SOAP-ME or SOAP-3-ME, for the simple, the mnemonic that you can use. You should have a suction ready, Yankers or the simple catheters, oxygenation flow meter. Airway equipment will contain the endotracheal tube, stellate, syringes, laryngoscope, blade, lubricating gel, and in the mask airway. Even for a difficult airway, you can use the adjuncts as well. Position pharmacy and personnel is important. The ones intubating, monitors, and entitled CO2 detectors. So these are the simple apparatus that you can use. It you need to have at least a size upper and a size lower, the one which you're choosing. Formula for the endotracheal size tube, which one the one which you're using. For the term infants, usually 3 to 3.5. Internal diameter 6 months is 3.5 to 4. 1 year is 4 to 4.5. And above 1 year, you use this formula of age in years divided by 4 plus 4. If it is an uncuffed tube, and age in years divided by 4 plus 3.5 for a cuffed endotracheal tube. We prefer a cuffed one, especially for the little elder kids, because it will prevent a leaking around the endotracheal size tube. How much do we do for the depth is that simply endotracheal type size times 3 at the lip level. So how do you confirm the placement if the endotracheal tube is in place or no? There'll be symmetric chest rise. There'll be auscultate in all the 5 areas of the chest. There'll be mist in the ETT, though it's a very rough technique that is used. So mist can happen even in the esophageal intubation. There'll be absent air into the stomach. For better monitoring, you can go for the CO2 detection. There are some detectors available in few places. We don't have it here. Normal heart rate and the SpO2 and skin color will improve. Direct visualization, like, when you, the one who is intubating the patient, he will know that the tube has gone down the vocal cords, and you can confirm it by the chest X-ray. What do we do about the ventilatory settings for the respiratory failure? Usually for, with the diffusion problem, like the pneumonia and ARDS, and those having PQ mismatch, we go for the high FiO2, high PEEP, and high positive inspiratory pressure. But for those who have central ventilation problems and those who have normal lungs, you usually go for the lower settings, because in those conditions, the lungs are normal. If there is acute deterioration, we all know the DOPE technique. DOPE is D is for displacement, O is for obstruction, P is for pneumothorax and equipment failure. So a patient who is already intubated, if there is sudden deterioration in the condition or there is sudden desaturation, always go back, displace it from, disconnect the patient from the ventilator, do the ambu bagging, make sure that there is a good chest rise, look for any secretions. If there is ET obstruction, do the suction. And if there is displacement, go ahead and change the endotracheal tube. Thank you very much. That was all for the respiratory failure part. And if there is any question, all of them will be answered at the end of the sessions.